Good afternoon, Chair Peters and members of the committee. My name is Naomi Lopez, and I'm the Vice President of Healthcare Policy at the Goldwater Institute, which is based in Phoenix, Arizona. Thank you for allowing me to offer my insights and expertise regarding Assembly Bill 188 as you consider this important issue, protecting the right to try to save one's own life without having to beg the federal government for permission to do so. The Goldwater Institute is a public policy research organization. We work through the courts, legislatures, and communities to defend and strengthen the freedom guaranteed to all Americans in the constitutions of both the United States and the 50 state constitutions. Reducing FDA red tape to allow patients access to potentially life-saving treatments and allowing medical professionals to practice at the top of their education and training are important priorities in our organization's healthcare work. Today, we are experiencing a medical revolution. New and promising treatments are being discovered almost daily. Some diseases that were death sentences merely 1 decade ago are now chronic conditions. And in some cases, some have been cured. And treatments using a patient's own unique and personal genetic information, for example, are now a reality for some illnesses and very promising for many, many more. Unfortunately, the current clinical evaluation system was created more than a half century ago, and it was intended to test treatments for large groups of populations. Would we want to seek treatment from a doctor whose most recent information was from the 1960s, or who was still using 1960s technology to diagnose a serious illness? Of course not. Today, we know far more about illnesses and diseases and how to treat them, which is why we've taken a leading role in the Right to Try movement. And over that time, we're discovering that diseases and illnesses can be very specific to individuals. For example, there isn't one breast cancer, there are hundreds. Just a few years ago, terminally ill patients were forced to endure the FDA's slow-moving approval process in order to access potentially life-saving treatments. Today, patients have new hope and more options under the original Right to Try law, which is now the law of the land. Thanks to the work of citizens and state lawmakers, including Nevada, Right to Try is now federal law and has opened new pathways for terminally ill patients to access treatments. Today, Right to Try is working. Dying patients nationwide have been able to pursue, with their doctor's recommendation and oversight, treatments that have passed basic safety evaluation, but have not yet received full FDA approval. It has improved and saved the lives of people with illnesses like cancer, ALS, and now COVID. Right to Try for individualized treatments applies this principle to the latest medical treatments. This proposed law does not change or alter the original law in any way. What it does do is it creates a new pathway for those patients whose rare or ultra-rare diseases are unlikely to have enough patients for a trial or enough commercial interest to pursue a trial today. And it would have helped patients like Kira Riley. The Riley family has 3 daughters. Olivia was just a toddler when she started regressing neurologically and physically. They had her tested and discovered that she had MLD, which is a very rare but devastating illness that affects the motor functions and neurological functions, usually of young children. Young children don't usually live past age 5 or 6. Since they knew this was a genetic disease, they immediately tested their baby, Kira. Kira was just a few months old, and they discovered she had it too. There was no treatment, there was no cure, but there was something being trialed in Italy. So during the height of the pandemic, the Riley family, who lives in the Phoenix area, raised $500,000, relocated their 3 children to Italy so that Kira could try this gene therapy. I'm very happy to report that in January, Kira turned 3. She is doing well, she's thriving, she's climbing, she's riding a bicycle. Very sadly, her sister Olivia is now in hospice care. They had to go to Italy. It doesn't have to be that way. You as lawmakers have the authority and responsibility to ensure safe pathways for patients like Kira Riley and many others. So similar to the Right to Try law for individualized treatments, this will have important and trusted safeguards to protect patients who are pursuing treatments. First, the law will require patients to have considered approval treatment options. Second, the treatment will have to be recommended by a doctor who is in good standing with her licensing organization, and they cannot be compensated directly by the manufacturer for prescribing it. Patients cannot be charged more than the direct costs of those treatments, but it certainly does not preclude insurance from paying for these treatments. Third, the patient will have to give written informed consent regarding the risks associated with taking this investigational treatment. And fourth, the treatment rule, the rules regulating these treatments and how this treatment is created and manufactured are governed by what's called the federal-wide assurance. This is a set of laws, rules, and regulations that already govern and have for decades these types of facilities that would be creating these treatments. Instead of trying to create a new regulatory scheme, we wanted to go with something that was already well known, has been tested, and would not require new effort and trying to test something that had not been done before. So I'd like to briefly explain what the law does section by section. The first section basically adds individualized treatment, individualized investigational treatment to Nevada's current law. Section 2 describes that the patient has to be diagnosed with a life-threatening or severely debilitating disease, which has to be attested to by their physician. It also basically waives the liability so that a private cause of action against a manufacturer or an investigational treatment or investigational drug or product against any person involved in the care of the patient, so long as they're following the law and so long as they are doing, they are acting in good faith, that cannot be taken. And this was the same kind of language that was used in the original right to try law as well. And we also, Section 3 basically adds additional language regarding individualized investigational treatments. And once we get to Section 5, that does something similar. I'd like to talk just for a couple of minutes about what the federal-wide assurance is and what it means. So a facility that is doing any work on human subjects has to, if they are taking any federal government money, has to abide by this set of rules and regulations. It's very comprehensive. So let's say, for an example, there's a Nobel laureate physician who wants to create a treatment. They are not allowed to go into a federal-wide assurance facility and make something. Just because they have a Nobel Prize does not give them that entree into the facility. What they have to do is they have to go through that facility's institutional review board and get approval from the review board to engage in activities within that facility. They also have to provide a treatment protocol. In other words, what is it that they're going to be doing with what they create? They have to be very explicit about what it is that they are making in that facility. And the institutional review board also certifies that all of the patient consent requirements have been met. In this law, we also make sure that as you know, the state has authority over the practice of medicine. We do not want to do anything that would undermine the state's authority to go after any bad actors. But what we do say in the law is that if there is a physician that's acting so that it is abided by the law, that they cannot be solely disciplined for that. Of course, you can discipline them if they're not acting according to the law or if they're doing something else. But we want to just be very, very clear that with this, nothing in this law changes or undermines the authority that the state already has as it relates to the practice of medicine, which we think is incredibly important because you do have that is within your authority. So I just want to close by saying that state law, we're in very divisive political times, but there is a way for lawmakers on both sides of the aisle to act in the best interest of patients. Doing what's right for patients has nothing to do with political party. It has nothing to do with how you vote. This is about making sure that your citizens have more opportunities to seek out the treatments that their physicians believe might be able to help them. Thank you very much for your time, and I'd be happy to answer any questions now or in the future.
Are there questions from the committee? All right, Assemblyman Gray, please go ahead.
Thank you, Madam Chair. And thank you, Assemblywoman Kasama. And ma'am, you guys, I was very happy to sign on to this one. This is a good bill. And you guys both answered my questions. First one was going to be about other trials and, what effect might happen there. And the other one's actually about the protocols. The question that I do have, though, that remains unanswered is, will they have to report to any higher authority or the IRB or anybody about adverse reactions or positive outcomes? I mean, will they, this won't be a study, but I mean, will they have to report their results at some point?
Chairwoman, Representative Gray,
You can
Naomi
go.
Lopez for the Goldwater Institute, for the record. So in answer to your question, will the results have to be reported? There will be a requirement at the federal level that the Department of Health and Human Services promulgate rules and regulations around the use of right to try for investigational treatments. We did the same thing for the original right to try. The final rules were just promulgated this past fall. And then as a matter of course, any adverse events must be reported to the FDA. This current proposal does not change federal law, and nor could it. And so that is still a requirement.
Thank you. Assemblywoman Newby.
Thank you, Madam Chairwoman, and thank you for bringing this bill. I just have a question of how it works on the ground level and what kind of docs we would be seeing or what kind of qualifications they might have. And I bring this up because it's been something that I've been working on in my professional life, but also up here in terms of clinical trials and trying to get that biomed sector built up here in Nevada. So I guess my question is, do we have to have docs in the state in order to not have to travel to Italy who are actually part of a clinical trial and certified to do that for whatever medical treatment it is that our citizen is seeking?
Chairwoman, Representative Newby, Naomi Lopez from the Goldwater Institute, for the record. Thank you very much for your question. So I think I'm going to answer it in I'm going to give you two different answers. So the first answer is any treatment that would be created or provided in Nevada would have to be approved by the institutional review board that governs that facility. So could you have a physician that was unqualified seek to make a treatment in the facility? Yes, absolutely. But the institutional review board would tell them no. So that would not proceed. And so we have many layers of protections in this law to make, and like I said, these rules have been around for decades and they work. We know they work. And so the same rules that would keep a doctor that wasn't qualified from creating a treatment last year would do so in the future. And so now to answer your next question, so from what we've seen from the original right to try law, we've seen a lot of innovations that we actually did not necessarily expect or plan for. But I think once you make the ground fertile, establish clear rules, and really create that pathway, then you have innovators and physicians come into the space and actually create new programs around treatments for patients. And so I do think, and I would be optimistic, that having a law like right to try for individualized treatments would garner the attention of manufacturers and companies to establish new programs that are not in existence right now, because the legal environment and the regulatory environment just isn't that friendly to that.
And Chair, if I could jump in, James Orange, State Senate District 21, to you and through you to Assemblywoman Newby. I think that this bill really will complement the teaching hospitals we now have in our state, in both parts of the state. I mean, I think about growing up here in Nevada, we had the medical school up here in the northern part of the state, and we didn't have medical school down south. Now, I think the opportunities for a bill like this to help in teaching hospitals that we have here in Nevada are just tremendous. Growing up here as a kid in Nevada, so many people, if they had a serious life-threatening illness, would try to travel to a center of excellence, whether it was on the coast or out in the Midwest. But here now we've got some of these centers of excellence here, and I believe a bill like this will help people struggling to find the right treatment be able to possibly get that here.
Thank you. Vice Chair Ornlicker, please go ahead.
Thank you, Chair, and thank you for your concern about access to investigational treatments. I think you're absolutely right. We need to make sure patients do have access. But I'm concerned because There's lots of concerns about this pathway, as I'm sure you know, and the FDA does allow expanded access for investigational treatments like this and other investigational treatments. According to one report, they approve more than 99% of requests for access to investigational treatments, generally within a matter of hours or days. What is different about this is, yes, as you pointed out, there's institutional review board review, but there's not FDA, Food and Drug Administration review, which is part of the expanded access. I've served on institutional review boards. They are important, but there's a lot of concern in the profession and researchers that IRBs just don't have the capacity to do the job that you want it to do, and that the FDA needs to be in the picture. So I'd appreciate your giving some more explanation why you think it's a bad idea to have the FDA play a role in making sure that these drugs really are safe before patients receive them.
Chair, James Orange, State Senate
Please
District
feel
21, if I could take a stab at that to you and through you to Assemblyman Orntlicker. My recollections, of working on the bill in 2015 was the feeling wasn't that it was bad for the FDA to play its important role, but what I had learned from constituents, from people I was working with, was that even though there was the compassionate use exception that the FDA has and other ways that people could try to work through the FDA, a lot of times we found it wasn't that fast. So I'm pleased to hear you saying that things are so quick now, but I know in 2015 a concern was not that the FDA did not have a role, but that they moved so slowly that some of these treatments that could help our constituents weren't being made available to them. And I don't know if you'd want to jump in too, but.
Naomi Lopez from the Goldwater Institute for the record. Chairwoman, Vice Chair. So I would like to point out that under the original right to try law in Texas, before there was a federal right to try law, Dr. Ibrahim Delbasan, who was former head of nuclear medicine at MD Anderson, and at that time was trialing a drug at his own clinic for neuroendocrine cancer. He had cleared the formal clinical trial process and was waiting for the FDA green light, which can take about 2 years after completion of the trial for the final FDA green light. He had patients lined up for compassionate use, and the FDA told him he had to shut it down. They had enough data. He was ready and willing and able to treat those patients. So he used the Texas right to try law to treat about 180 patients with neuroendocrine cancer. Some of those patients were flying to Germany for treatment. One of those treatments was a VA veteran who mortgaged his house to go to Germany to try to save his life. These are examples of how the FDA falls short in putting patients first. I would also like to point out, you may not remember, but Representative King and Majority Leader Pelosi at that time sponsored a private bill for J.C. Hempstead. She was a twin with ALS. Her sister had already died. They were trying to get a treatment, an individualized treatment, bespoke for J.C. for ALS. The FDA said no, and they had to, and so Representatives King and Majority Leader Pelosi ran this private bill. Now that pressure forced the FDA's hand, and they were able to move forward with the treatment. But it's these kinds of obstacles that the FDA will not tell you about. That is the reason that we do need this type of law. 2 weeks ago, at a nationwide conference, one of the FDA directors basically said that because they didn't have the capacity to do more Zoom calls, they could not rectify small problems in applications to move a treatment into clinical trials in the first place. The capacity of the FDA is limited, but there's also the principle of whether or not a federal regulator should get a veto stamp over whether or not your doctor thinks that you should get a treatment that they think might help you. And so that is why we're moving forward with right to try for individualized treatments. Patients don't have time to wait on the FDA. And as state lawmakers, you have the authority to move forward and create this pathway so that your citizens don't run out of options, so that they don't have to travel the globe, and so that they're not put in unnecessary danger of seeking treatment from people who aren't working in their best interest.
Any follow-up? Thank you. Assemblywoman Taylor.
Thank you, Madam Chair. And thank you to our colleagues from the Assembly and the Senate, and thank you so much for being here and for your work. I just have a question. You mentioned the state of Texas and kind of looking and modeling around what they've done. What other states, or is it predominant across other states that have this? I love how you call it the right to try. Well, as a cancer survivor myself, if I needed experimental treatment, I would have wanted to be able to try. So I certainly understand that. So what does this look like in other states?
Chairwoman Representative Taylor, Naomi Lopez from the Goldwater Institute for the record. Thank you for your question. So the original right to try law was passed in 41 states, including Nevada, before it became federal law in 2018. The current right to try for individualized treatments, which does not affect the original law, but simply creates a new pathway for individualized treatments, has been passed in Arizona. It is now law in Arizona, and we have introduced it in multiple other states that are now considering it.
A follow-up, Chair? Thank you very much. So really, the individualization, which is clearly pointed out in the legislation, that's the newness, I guess, to this, and it'll be going on across the country. And just one more thing, it's Nevada. You're gonna get more votes. You're gonna get more votes if you say Nevada. Just a little tip for you, little tip. Thank you, Madam Chair.
Well, I was laughing so hard, I don't remember if you had a question. Okay. Are there other questions from the committee? Oh, I have one. Can you give us, I know you briefly went over the criteria for patients as it's kind of written in the bill, but can you give us an idea for the legislative record of what kind of criteria a patient would have to meet and what the doctor's expectations of that patient would be prior to requesting this authority or being approved for the authority to do a trial treatment?
Thank you, Madam Chair. Naomi Lopez from the Goldwater Institute for the record. So under this current law, the patient has to be facing life-threatening or severely debilitating illness. That is defined in federal law, and we use that in order to create the state versions of the legislation. The patient has to have considered other FDA-approved treatment options, as well as those treatment options that are in clinical evaluation. The physician has to be recommending that treatment, that specific treatment for that specific patient, and has to attest that the patient does in fact meet the criteria for, in terms of the seriousness of their illness. And the patient has to also provide informed consent. There are several layers of protection of informed consent, which is at the state level, but also through the federal-wide assurance. So there are multiple layers, and so they have to also be informed of the risks to both the negative and positive outcomes as possibilities from the treatment.